So thank you for having me. I'm really looking forward to talking to you about what I've been spending a lot of the last year doing. And you have the clicker, John. Okay, so there we go. So I have no financial disclosures, but that is my reason for going to work every day. Those are my 2 kids. And I've been obviously participating in the Fellowship Council EPA pilot project this year. Oops, I'll go back there. So these are, clicker is really happy. Okay, 1 second here. I don't know why it wants to skip that slide, but I don't know if you can just advance it 1 slide there for me. There we go, thank you. So these are my objectives for today. So I'm going to briefly define a few things that everyone hopefully in this room is very familiar with, is competency-based medical and resident education, what are EPAs and how they fit into that puzzle, reviewing a few of the best practices with CBE strategies, outlining my home country of Canada and what the Royal College has been doing, as well as the American Board of Surgery in the US, and then going on to the Fellowship Council EPA pilot project, which took up a lot of my time this year, which was a great endeavor, describing the creation and implementation that occurred before me, and then also the lessons that we learned throughout the year. It's just a mess. So historically, as you know, assessment of surgical trainees required a fixed number of successfully completed rotations or a self-reported case log with an attempt to standardize things with a final exam that was, just a written or an oral component. This generates a very varied outcome in terms of competency of our surgical trainees, as Dr. Mellinger had outlined. Competency-based medical or resident education proposes not to fix the training, but to fix the outcome, and to make that outcome a minimum standard of competency that one must achieve in order to be ready to practice. We all know different residents that, you show them something once laparoscopically, they can do it right away. Another resident, it's gonna take a few more cases to get there, and that's okay. We all have different learning curves or different aspects of our training, and maybe that's not the part that needs to be focused on, it's more the outcome. So why the change? Dr. Mellinger went over many of these studies already. There's increasing specialization, there's more to learn, less time to do it. We're to have decreasing autonomy because of patient concerns for safety. The public is demanding that we have more transparency in our training, and this is one way to do it with competency-based residency education. And as Dr. Mellinger pointed out, 23% of graduating chief residents are not able to, or were not prepared to work independently, and there was 2/3 of fellows were not able to be left alone in a major operation for more than 30 minutes because they weren't able to progress. And so that's something that is obviously a concern. So while the idea of competency makes a lot of sense, it is difficult to implement a competency-based medical education model into practice. EPAs, or entrustable professional activities, were designed to bridge that gap between theory and the real-time evaluation in the workplace. EPAs are the actions or units of professional practice defined as a task or responsibility that is entrusted to be completed by the trainee, and then that task is then objectively evaluated using a scaling system I'll show you in a moment. In reality, we make these decisions daily as we allow our learners to complete tasks with decreasing amounts of supervision as they gain competency. This structure just makes those things that we're already doing quantifiable and allows them to be incorporated into formal evaluation. So across the world, there are many different places that are already doing this and many models that are being created, and these are just a few of them in recent literature, but there's many, many more. I'll start with, so all of the original research started with Dr. Tenkate in the Netherlands back in the early 2000s. And then from there, the Royal College of Physicians and Surgeons of Canada really took that and created this competency by design curriculum that I did not have the pleasure of being involved with as a resident, but came just shortly after me. They started in 2017 with their ENT and their anesthesia programs, and in 2020, which I just missed, for the general surgery residency program. And what's unique about this is that it's all specialties, all disciplines, and everyone is now doing this. And I believe now all of the programs are all on this competency by design. So what they do is they take, each program has made their own EPAs and milestones that they deem that need to be accomplished by the time a resident is competent to be graduated. They then take those evaluations, assess the resident in the workplace, create an e-portfolio of all of those assessments, and then there's a clinical competency committee, which is probably the best part about this, that really makes these decisions on a quarterly basis. How is the resident doing? What can we do to improve? And do they need an individualized education plan to help them achieve their milestones? Yes or no? Or are they doing well and progressing? And those decisions is really where I think the value is in this. American Board of Surgery pilot project was also done recently, just completed last summer, and some of those results have been published by different institutions. Despite having done, I believe there was over 30 EPAs that had been created, they only utilized 5 in their pilot project just to really highlight the core competencies for general surgery. And I'll talk about some of the results a little bit later. So for the Fellowship Council pilot project, I'll spend a bit more of my time here. This is how it initially started. So this slide was from Dr. Minter, who did a lot of this work originally. But basically, with the different domains of GI surgery, and the working groups were created with the minimal standards defined by the various meetings, including SAGES and other membership committees that define these standards, and then created these EPAs through that. And so that was all started back in the 2010s, and 2017 was when they really started writing these EPAs. This is the final master list of EPAs that was utilized for the pilot project. I'm not going to go through them in great detail, but there were 8 abdominal wall, 5 bariatric, 10 flex endo, 5 foregut, and then 10 HPB EPAs, and each of these have different subsections to them. So each fellowship category was then able to select from that list. I showed you the core set of EPAs that were required for their fellows to complete, and then of course, if you're on off-source rotations, you can select other EPAs to help build your portfolio. So this is what our grading system was developed. So it's the same as the American Board of Surgery to keep things consistent. So if you have different learners, you don't have to switch gears when you're trying to evaluate them. So going from level 0, which is someone who can't really do much but observe, going up to practice-ready fellow. So this is me filling out an EPA, just so you know how simple it is. So it's in the same area as where our case log is, but right next to you, click EPA, start a new EPA, pops up. I'm going to pick Jerry Freed, and then I'm going to select what date and time this case or clinical encounter was. Then you go to your case description. You can click, was case 3 of the day. This is not a real patient, but 55-year-old gentleman with a recurrent inguinal hernia. And then which category this EPA falls into. And this is just so that Jerry knows which cases you want me to evaluate. I go in there, click abdominal wall, go down, find the right one that matches with it, and then you're done. So, and then pre-op, post-op, or intra-op, send it off. So now Dr. Freed will get an evaluation, and then I have to complete my own self-assessment. This is the part that, and then it just loads up. You do your own self-assessment, make sure the data is correct on the top. And then here, this is where the observable behaviors for each level are there. So it's really easy. You don't have to go back and look back and forth. You just say, which paragraph describes what I felt I did? And this is, let's say the middle of my fellowship, I'm like, yeah, this is level 3. Then you fill out what I did well, what I can improve on, and then optional feedback. And so that only took about a minute. Then basically, this is what comes out when it's generated. So once the staff fills out their half, you get to see it. They have 72 hours to complete the evaluation. Usually they're done within the first day, and then hopefully they match. And if they match, that's great. This is from earlier in my fellowship. And then these are the comments that can be generated. It can be as detailed or short as necessary. And then it really helps you know, am I on the same page as my attending? What can I do better, etc. So bearish implementation, of course, anytime we change something, people don't want to change. We like what we have. We don't want to ruffle feathers. We don't want to change what we're doing. But we know that we need to change. There is a cost associated with setting up these platforms. And this is basically, these lists were all things that other people had found within implementing CBD that was difficult. And we don't want to create more work, but we also want to make sure that our work is meaningful and what we are doing is being evaluated in a meaningful way. And so, and the lack of representation of pre and post-op EPAs for surgical programs has been identified as a problem. But I would argue that for fellowship, maybe it's not a big of a problem because really fellowship is where you're trying to hone your surgical skills, and a lot of that should have been learned before you get to that point. So this is our preliminary data. We're still kind of working on it. I have a bunch of numbers to crunch, but basically we found the same things as what some of the other pilot projects found, is that we had about 62% completion rate for the EPAs, which means that there were 38% of the time a fellow was disappointed that they submitted something and the staff didn't complete it. So that did create a barrier. Also, we found that intra-op EPAs were, of course, more preferentially completed. Only 2 EPAs of that entire big list I showed you were not utilized, and both are for the flex endo group. And that makes sense because there was only one fellowship program that focused on flexible endoscopy, and so that's not too abnormal. And there were 10 EPAs from there. Average time to completion was under a day. And we also did a survey at the beginning and the end. And our survey found, interestingly, like I mentioned earlier, the clinical competency committee was the most valuable. So the feedback that we got quarterly was excellent. So you had very specific feedback as they're able to look at your EPAs, look at everything else that you're doing, and then give you very meaningful and tangible feedback. Barriers identified were, again, similar to what is found in other research articles on this. Early technical issues, there was some bugs with the system we had to work out. There's still ongoing things that could make it easier, linking it to the case log, other things that we could do going forward to make that easier. And there's always a thing about fellows forgetting to initiate EPAs or attendings forgetting to do it and then creating this, difficulty there. And that's a big thing there. So those are most of it. So future directions don't have a lot of time, but we can ask more questions about this. But I just wanted to say thank you. This is obviously Dr. Feldman and Dr. Vasiliou, who were my fellowship program directors last year, and I just thank them for getting me involved in all these projects.